And thank you so much for your patience and accommodating the changes in the agenda. For us, it's been a hectic day because we cannot cut the quality of the presentations that are making here and some of time for a little bit of questions and answers. But still, it's really a challenge to create a hybrid environment and making a good synchronization between the auditorium full of people, as much as COVID allows us to be full. But we have here an incredible group of participants on site. Also, thank you so much, Zoom participants and everybody that is watching us on the social media. Thank you for following us. I know that you're probably very, very pleased with the outcomes of the content that we have shared today. Amazing contributions. And now we are going to do the closing plenary. I'm just calling here on Urska to make a quick check, and if we have our panelists with video on the Zoom, so we can start. As apologizing also Jan Mcneillo, as John Meredith for the delay. It's been hectic, but also a little bit late on your times of the days. We also have Dr. Petra Wilson in the UK, our time, and Dr. Sergio Pillon, which I already see with a nice environment from Italy. And Dr. Sergio Pillon was a repeating guest speaker because of his innovative work, and I'm sure that NOC Care should be interested on that perspective, because telemedicine massive adoption in Italy. Sergio, welcome to this closing plenary, and apologize for the delay. I know that you as an Italian understand it.
Yes. You know, well, Italy is from north to south, and we are used to say that 7:30 in north is exact, in the center is around, in the south is what kind of gun is 7:30. It's a joke, but sometimes a joke could explain the truth.
Absolutely. Welcome, Dr. Petra Wilson. Welcome, Dr. Ian Mcneillo. So good to have you here on the Zoom Mosaic, and also very, very pleased to have here on our auditorium this beautiful place. I wish you could be here to see our environment. Maybe the regie can put us later on a perspective different from this nice video forecast we have here. For our the share of the session here is already in place. Dr. Ponciano Oliveira, executive board member of a regional authority in the north of Portugal, Regional Health Authority, one of the most, if not the most innovative region in these countries, pushing the boundaries. And it's an honor to have him here, because Dr. Ponciano Oliveira himself is an innovator. He's been contributing from many different directions to innovative projects in the region that are then expanding to the rest of the nation. And it's something of a personal esteem I have from his presence, and the fact that he's accepting here to be and awarding the certificates to our global shapers that are here to have them on site, and then virtually send by postal services the other certificates we have here from the Faculty of Medicine of Porto University, MUB. With us also in this session is the chair of the session, sorry, is Professor João Fonseca, as for the moment I was confusing. Dr. Ponciano Oliveira is a guest speaker that is coming for the delivering of the awards. Professor João Fonseca, co-host of this session, already opened at the floor this morning with very kind words, and is going to also be with us in the guest speakers dinner that we are organizing for everybody that is been invited. Professor João Fonseca is leading MedSeeds, which is precisely the core of the innovation in terms of a new undergraduate bachelor degrees that you can have in digital health and translation medicine, very innovative. We already during the day spoke about this need for this kind of educational offers, and it's very interesting that the convergence of this Health Data Forum Global Hybrid Summit is taking place precisely here. It's maybe not casuality. North of Portugal, Faculty of Medicine of Porto University. It's amazing to have these contributions in the table. Also, John Meredith, welcome. I was making the time for you to show up. Really great to have another innovative health region, Wales. Unfortunately, we could not set the organization enough in time for you to be here with us in present. It will be really a pleasure. I'm sure that on other occasions in the future, maybe you can. John, as this pandemic still is taking a toll on all of us for the moment. And from the US, if not, we will not be global. Dr. George Matthew, is a digital health expert, chief medical officer. He's been in different kinds of organizations. He's a medical doctor. Is now a chief medical officer of Dataless, and it's a company that is really aiming and transforming healthcare with data. So George, welcome, and it's a pleasure to have all this ready. So I think that without further ado, we can start this session. Let's think that perhaps Professor João Fonseca would take the lead now as a chair and organize the speakers according to the schedule. You have the schedule. If not, I can borrow you this one here. Over to you, and good session.
Thank you so much. Welcome to all here and also in Zoom. And it is really a pleasure to be physically, but also going forward. I don't know. I don't need the paper. Thank you. I have the digital part. But yes, hybrid also from digital and paper, or digital and physical, is still the future. And I hope that it remains that way, because really it allows us both to have the best of both worlds. And I will not take long. And Paulo already made the introductions actually of the speakers, and also my co-chair and Dr. Ponciano, which is, has been said, really a leader in the region and in the innovation in the region. It's always a pleasure to have to be with him and to co-host a session. So let's start, and I would like first of all to welcome again Dr. Petra Wilson, Director of IMS, and it is a pleasure, and I'll give you the floor, let's say. Thank you.
Thank you very much indeed. It's a pleasure to be with you. I'm very sad that I'm not able to be with you in Portugal. I had the great pleasure of being in Portugal just last week, working with some of your leaders in digital health there, but unable to travel again this week. I've been invited to speak on this closing plenary from the background of HIMSS, and I'm going to start by sharing a little bit about what HIMSS is doing, and then to relate that to what is happening in the European health data space. And I know we've already spoken about the European health data space today, but I will just refresh our memories a little bit about what the objective of this big European initiative is, and then I hope have a little further discussion around that. So I am going to share my screen, and I hope then that you will see my slides. I hope then you will see my slides. Yes. Are you seeing my slides now?
Not yet, but I am.
Okay. You should be seeing my slides. Okay, that's not going to work.
I will start sharing, Petra, and you will just say next slide. Okay, give me 1 second to download your presentation and start sharing, but please just begin with an introduction.
Let me see again if I can share that. That should be possible. You should be seeing my slides now. Yeah,
working now. Thank you.
Okay, very good. Then I just need to see if I can move through my slides, which is also not happening right now. Okay. Okay, yeah. Okay, so we're in the right place. Thank you. So the title of the stream is the future of healthcare data-driven? And I just want to go a little bit into that in a moment. But first, let me refresh you about what HIMSS is. So HIMSS is the Health Information Management System Society, and we are a global advisor and thought leader supporting the transformation of health ecosystems through information and technology. So we share the objectives
Petra,
of...
I think we are just looking your presentation, but not in presentation format. I mean, we are blocked on the last slide.
You're blocked on the last slide. Okay.
Yes, Petra, as I've said, I'll try, I'll begin sharing the presentation on your behalf, okay?
Okay, unfortunately, that won't take account of changes that I made, but never mind, we'll work with it.
Yeah, okay, give me, just continue with what you were saying and give me 2 seconds to start sharing.
Okay, so it means I can't really see what you're seeing, but I was telling you a little bit about what HIMSS is and
okay,
to share with you.
If you could, yes, you already stopped sharing your screen. Thank you. Yeah.
I've stopped, I believe.
Yes, yes.
Yeah.
Go ahead.
Okay, so let's just try and make this as easy as possible. Thank you. You are presenting something now. Thank you very much. And if you already move on to the next one, please. So I wanted to share with you something of our vision and mission, which is to realize the full potential of health of every human everywhere. So a very ambitious ambition, and to do that through the reform of global health ecosystems, through the power of information and technology. And can we go to the next slide, please? We do this by our work with people like you, the influencers, the governments, the public-private sector partnerships, the technology vendors, the policymakers, the financiers of healthcare systems, and of course the healthcare education providers, through our 100,000 plus individual members and through the stakeholders who we work with, notably stakeholders such as SPMS in Portugal. And we're very grateful for the work that we're able to do with you. If I could have the next slide, please. So I want us to just consider briefly whether the future of healthcare is indeed data-driven. And I hope that some of you here will recognize the image of the car which is on the screen. It's the car from the Back to the Future films. It's the DeLorean. And the reason I've chosen that, and the other image is of Hippocrates, is that, yes, on the one hand, we are moving forward into a time where healthcare is driven by data. But actually, even Hippocrates already told us that data was the foundation of good healthcare. He didn't call it data, he called it obtaining information from the patient. But remember that Hippocrates urged us, he said, before we lay hands on the patient, we must open our ears and hear what the patient has to say. So we were already being implored then to step back, to listen, to observe, to hear the data, to hear the information, and to then treat the patient. Of course, what's changed since Hippocrates' day is that we now have many physicians and many other sources of data, and we have to find ways of sharing that data. So I would say the future is healthcare driven, is data driven, but it is also a case of back to the future, because we have been doing this for a long time. What we want to do is learn to do it differently. And with that, I'd like to move ahead to talk a little bit about the European health data space that you've already heard about today. So Oskar, if you could just move ahead to the slide depicting the European health data space, which I believe might be the next one. Yeah, thank you very much. So the European health data space is an initiative of the European Union to seek to facilitate that data sharing, to share that data for 4 broad areas of work. The one that we're almost familiar with, which is sharing data for the purposes of healthcare provision, but also recognizing that it's not just about the sort of data that Hippocrates urges to share, but that it's also about understanding the needs of healthcare providers and using data to drive better research, better policy making, and thereby better healthcare systems and services. But the Commission is, of course, also focused on the European aspects, which is about creating a single digital market in health services, for making real the possibilities opened by the Cross-Border Care Directive. And finally, it's about recognizing that the future of healthcare will be driven by artificial intelligence, and artificial intelligence cannot happen without data. And so the European health data is, if you like, our DeLorean vehicle. It's the car through which we will get through to a data-driven future. Could I ask you, Oscar, please, to go to the slide? I think we may have to go back and one more back. Thank you. Sorry, the one that you just had after Hippocrates. Thank you very much. This is the, I want to share with you HIMSS' vision of where we are going in terms of advancing the digital future of healthcare and data-driven healthcare. So we have the European Health Data Space, which is a driver for sharing data, but that in itself requires many other channels. And the 4 big issues that we're focusing on in HIMSS are technical, legal, and operational interoperability, which will in turn drive connected health, but which must be always conscious of and serving data privacy and cybersecurity for healthcare, in order to arrive at the final pillar, which is a value-based healthcare system. And all of these are driven by fundamental values, and those are depicted at the bottom of the slide. I'm not going to read through them all in the interest of time, but I do want to draw our attention to what our ultimate objectives are. And our ultimate objectives are to drive health equity, to be prepared for future emergencies and pandemics, to support population and public health, and of course to use that data-driven healthcare economy to also drive workforce development, so that we have a healthcare workforce that is able to make best use of the data. And I think with that, I'll leave my opening thoughts and hand over to the next speaker. Thank you very much for your attention.
Thank you. Thank you, Petra, so much. And we'll continue with Ian Mcneillo, someone who already knows well this medical school, since he has already talked to us with our master in medical informatics a few years ago, and very well known the OpenER project. So thank you, Jan. Can you please put your mic on?
This helps put my mic on. Apologies.
Thank you.
Yeah, thank you. Can you see my screen share?
Yes.
Yes, thank you. And thank you very much for the invitation to join you. I am really sorry I couldn't join. I had hoped to visit Porto. In fact, I booked my flights, but I was a little unwell at the start of the week and decided it wouldn't be a good idea. COVID negative, thank you. Thanks. Anyway, so is health data driven? Health has been data driven for many years. It's a lot of it's on paper, but it is an information centric environment. My background is as a family doctor. I'm talking to you today really as a representative of a community known as OpenEHR or OpenAir, and I'm a director of OpenAir International, which is the not-for-profit which manages the intellectual property, which is all freely available and open sourced. And it's my job to maybe persuade you that there is a different way of approaching some of the problems that Petra mentioned, particularly in her slide about the EU data space. And I guess there's lots of discussion about what we mean by interoperability. And I tried to take a step back and say, well, what is it we really want here? Well, what we want is something which accepts that this is an immensely complex space in data terms and organizational terms. It doesn't matter which country you're in. We have something which is highly distributed, highly granular, lots and lots of different organizations and professionals involved. What we would like is for this to function as if it was a single coherent system. We don't have that now. And if we look at, a typical cancer journey that a patient might take, they will, even in an increasingly digitized environment, will actually encounter a large number of applications, all of which are trying to tell part of the story, but they're doing it in their own way. They are siloed. They're siloed both in terms of their user interfaces, but the information models and the data is locked into their own proprietary systems. Curiously, even if they are open source systems, they don't standardize the data in any meaningful way. So how do we get around that problem? Well, one of the ways that people have thought, probably 10 years ago, the phrase semantic interoperability came to the fore. And this really came, we can use this science of ontology to solve this problem. We can have a lingua franca based around ideas of logics. And, we just have to find some kind of truth in the logic of the kind of information we record, and that will solve the problem. Now, indeed, it solves some of the problem, but people, I think, unfortunately got carried away, decided that it would solve the whole problem. And if health records were purely biological, records of biological function, then that might be the case, but they're not. And much of the information that are in health and care records is not biological. It's about what we do and why we do and what we think. It's about opinion. It's contextual and it's cultural and it's arbitrary. It's not particularly truthful in a scientific sense. And we have to negotiate that world, as well as make use of the good things that ontologies like SNOMED, CT, etc. can do within this information space. So part of the solution, or the whole solution. And the other, this is not an and/or. We would use semantic interoperability in the exchange interoperability space, but this is how most attempts at interoperability are focused. Let's accept that we have everything in its own little siloed space inside multiple applications with their own ways of thinking about the information, but then let's construct some agnostic models of, a bed or a blood pressure or an allergy. And then we try to read and write the data between these different systems. You can see there's a lot of cost and complexity there. And whilst technologies like HL7 have definitely moved this on enormously, a number of us worry that actually we're still going to have a major problem getting this to work coherently. Maybe we just give up and say, look, let's just go back and buy one big system. And you see this coming around time and time again. There's a rumor that NHS England are thinking about just reaching out and saying to Epic, look, just sort all this out for us. I think most of us who've been in this space will understand that this is not a great way to go. Monopoly is never a good idea. No matter how good the company might be now, is this really what we want to do, is to hand over a huge amount of infrastructure and IP to a very small number of vendors. There's a variation on that appearing, and Forbes had a very interesting article, which is to say, the EHR is dead, long live the EHR platform. And that's certainly a journey that I've seen in the UK, not just with big hospital systems, but many of the GP systems are gently transforming themselves into platforms by exposing their APIs and their data management functionality to third parties. And that's a good thing, but it still leaves a huge chunk of IP and control inside a very small number of vendors. Okay, they're exposing their APIs, but they still got that huge amount of control. What we're seeing now is a new thing. And this is my world. This is what the Open EHR community has been pioneering for some time, which is to explicitly separate the apps from the data, make the apps user-centric and purpose-centric, make the data patient-centric. Critically, in this world, we strip away the information models and vendor-neutral data stores away from the applications completely. And we build shared and standardized data models built by informaticians and clinicians. It's a kind of no-code deployment, so we can deploy those shared information models, things like allergies, how do you do meds, how do you do more complex things like end-of-life care, apply those to vendor-neutral data stores. And then, of course, we allow the market to come in. So this isn't about one single system, but it's about trying to build those multiple systems around shared data stores that are patient-centric, trying to get a coherent model. And then we can build a lot of standard services and reduce the burden on new entrants to the market by doing some of the hard stuff around the platform, rather than asking all of these individual applications to figure out how to do prescribing services in a particular country. It is now happening at scale. So these are all examples just in Europe, and there are many more around the world, of open healthcare platform-based systems. Some are single applications or single vendors, but increasingly we're seeing regional and national systems. John's coming up is going to talk about what they're doing in Wales, but the other major area that has gone down this road is Catalonia. They've got this is to be their regional strategy going forward. So if you'd like to know more about this, a good place to start is this very recent event. It was held just last week in Berlin. There's a set of very good presentation slides and video recordings that will take you to some of the real examples. It's an exciting time, and we think this is probably where the market is going to go over the next 10, 20, 30 years. Thank you.
Thank you so much, and we continue as fast as possible to George Matthews, to Dataless America, and thank you and welcome. You can start and share your screen.
Thank you. I actually did not get a screen or a slide in time, so I'll have to do this off the top of my head. I hope that's okay. I'll try not to use too many hand gestures and whatnot.
Even better, even better.
Thank you so much for letting me join. As I've been listening to my fellow panel members, I'm struck by the similarity in some of the observations we're making. You know, the US, as you know, like anything, is we always have our own take on it. It's not always right, but it is unfortunately what we have to deal with. So as you'd said, I am the Chief Medical Officer for Dataless in North America. That's part of our Dataless Global organization, which is probably more familiar with some of our European colleagues, since we do play more of a role in NHS or in some of the EMRs in Spain and whatnot, obviously Middle East, Australia, New Zealand, and in Africa. But we're kind of here in North America. So what we deal with here, just to set the stage, as you know, we have probably one of the largest for-profit healthcare systems, if not the, in the world, which is really made up of smaller for-profit entities that work at multiple levels. We separate them typically in payer, provider, and life sciences, as well as the federal government, and state government takes care of some things as well. Here, what we focus on mostly is interoperability. We are behind a lot of our colleagues across the Atlantic in terms of trying to get folks to open up their silos and share their data. And while our platform here is able to, you know, it's built to allow for the transfer of data using smart on fire standards, transferring HL7, claims data, ADT data, and the whole slew of alphabet in terms of transferring data. What we see more often is the difficulty of changing existing business models to allow for this type of interoperability to happen. Most of, as you know, the healthcare here is for profit. And now that data has been, excuse me, health data in particular has been recognized as not only a financial asset, but also a competitive advantage. There's even more incentive to keep those silos up. So there are laws that have been passed through to try to promote interoperability, which we are trying to work with their timeline. But it is taking a lot more time than we would like to be able to get that interoperability, those interoperability laws in place. So as we're seeing the market evolve here, what we're starting to see are trends that are evolving. And again, like anyone else, we can try to forecast where this might go. Hopefully we'll learn some of the lessons from looking at you all and seeing how you all are doing things. And hopefully we can adopt some of the best practices. But as I said, with a for-profit mentality leading the charge, it's very difficult to mount a public health response, as we've seen with the recent COVID-19 pandemic. So when we look at it, the trends that we're seeing here, you know, I think one of my colleagues had mentioned this before, data-driven healthcare. And the way we are seeing it, data is good, but more data isn't necessarily better. What we've started to see is this shift towards, well, first we need as much claims information as possible to analyze it and put it through the algorithm and try to forecast what's going to happen. The limitation of it being that it's based on payment models, right? I will get the service, have a claim filed, and within 90 to 120 days, I should get some type of response financially or an error on the claim I filed. We started improving that data with some of the HL7 EMR data that we would get as well to see if that would actually help with giving us a more robust picture of patients. And that's turned out to be less than complete as well, not surprisingly. So now it seems that the view is turned towards getting what we're calling social determinants of health, or more accelerometer data off of phones, or trying to get people to engage with apps. So we're looking at a variety of data to create a more complete picture of the patient, but I don't know if that's necessarily helping the patient. Many of the companies and apps that are coming up are promoting their aspect of healthcare, whether it's mental health or diabetes care or whatnot, and it's not being integrated into a whole system that can help the patient. So while we are trying to help our clients figure out how to harmonize their data, how to tag their data so it can be queried for later use, we're really trying to get them to think about, what is your use case? What are you really trying to accomplish? Is it just a single isolated diabetes program, or are you trying to improve the whole health of the patient? And those are hard questions, because as the businesses are here, especially in healthcare delivery, many systems are compartmentalized. So there isn't as much financial incentive to work across multiple sectors or multiple departments. So we are trying to encourage them to think about this in a more global sense. The second thing that we're seeing is technology is good, but what we really require, as I said before, is business model innovation. Most of the care in the United States is delivered at a fee-for-service model. The more times you turn the turnstile, the more we get paid. And to shift it towards value-based care has been a challenge, if only because, as the best we've been able to do is dedicate resources to potentially both models. Ultimately, the providers have had to take some type of capitated risk to determine if they can actually manage the financial aspect of not having patients come through and fill a head in a bed, as we would term it. But it hasn't been enough. And we're still on the concept of, how do we make more money? And I think in some ways that's more of an indictment of how our healthcare system works here in the States. When we look at the metrics and how success is measured for any organization, healthcare or otherwise, it's mostly based on quarterly and annual profitability. It's not based on, did you improve the healthcare level of your constituents or your panel of patients? And though that seems strange, I bring it up because it's becoming more and more apparent as more data becomes more available. People are looking at the health of their communities and looking at their nonprofit status hospital in their area and realizing that while they put on $1 billion wing, people in that local area are not getting the care they need. So I do think that there's giving a rise to almost a do-it-yourself model where people may actually reject technology and try to come up with a level of care they can afford. Because at least in the States, healthcare is becoming a luxury item. Unless you have the deep pockets or insurance, you can't get it. And to note that this is becoming more important as patients become more aware of how to take care of themselves. I have a colleague who's actually at the Barcelona Health Hub conference today, who is presenting as a patient, talking about how patients need to be brought into the co-design of healthcare. That's something I don't think we would have even heard of 5 years ago. But patients are demanding a voice at the table because the care affects them. That is kind of the next trend, where because it gets more cost prohibitive, patients are looking for ways to hack the system, get the care they need when they can't afford it. Technology is becoming cheaper. And if they don't get the type of care that they would get from a normal healthcare system, they will try to get it any way they can. We see a combination of this and decentralized technologies as a way of patients to circumvent the system and collect their own data. And then as a collective pool, start negotiating with current healthcare incumbents to try to get the care that they need or want. We're probably more than a few years away from that, but we are seeing green shoots happen even in the United States. I think other countries are ahead of us. And we are starting to look at models of innovation in Africa, in India, in China, the old CK Prahalad bottom of the pyramid innovation, where when you have a scarcity of resources, how do you innovate? And then how do you share those innovations? We have areas of the United States that are very similar to that. So we're starting to see those models pop up. And last but not least, and Petra, I believe you actually have this in the model for HIMSS in Europe, privacy. And unfortunately, here in the US, it'll be privacy at a premium. We don't have a GDPR, as you know, and the attempts we have in California, Virginia, Arizona, I believe, and others are all being held back, not just because of healthcare reasons, but because of other larger multi-billion-dollar companies that are dependent on data privacy not being a protected right. Unfortunately, healthcare does fall under that category because many companies are circumventing a lot of the typical consent laws for patients that come into a hospital, similar to filling out an end-user license agreement and obtaining that data from patients without really telling them how it can be used. It's becoming more and more apparent post-Cambridge Analytica that data is being used without proper consent. But whether we get to a privacy law here it remains to be seen. However, companies such as Apple are now offering some type of privacy at a premium if you're willing to pay the price, the right to be forgotten. How that develops in healthcare remains to be seen. But I do think more and more people, as they're trying to find that level of trust in the equivalent of a healthcare professional, to not share their data without their permission or not use in a way that can be monetized, that will become more desirable and may allow for a stratification of different healthcare services. These are the trends that we see. Obviously, we could be wrong, but we're trying to make sure our interoperability platform can support it. I apologize for going so long, but I hope that was helpful. Thank you.
Thank you. Thank you, George. It's really important to have a different views from around the world and very different healthcare systems. Also in Europe, and now we'll go to Italy with Sergio Pilon, which will have a more mixed system, such as we are actually in Portugal. So welcome and please start.
Thank you. Thank you very much. I'm sharing my screen. Well, I'm not talking about problems, so we have many, but I will try to show what are the solutions. The solutions we are planning in Italy, this is our idea of telemedicine matrix. You have health and care action. Then you have specialties. I'm a doctor, so this is a doctor point of view. Then we have place where health and care are provided. With this matrix, you have to have people. What this means, digitally remaster health and care. Just say the action, telehealth, telemonitoring, tele-rehab, tele everywhere. But specialties, I mean, cardiology, just early intervention, lifestyle, any kind of different action for every specialty. Then you have emergency room, home offices, nursing home. Then we have special environment we will introduce with the next generation EU plan. Casa della Comunità, Ospedale della Comunità. This is really complex scenario. Then you have people with social culture, family, omics, place, income. Place means close to the hospital, far from the hospital, and everything. With this matrix, we are trying to also put the environment in the healthcare. This is just the work we have done This is the amount of CO2 saved in 7027 televisit. We are working not only for money, around money, not only around movement, but the environment. This is the model we are planning with the Next Generation EU. We have acute hospital, we have nurse hospital, only 4 hours a day for doctors. Then we have a community house, hub, 24 hours open. Community houses spoke, then we have home, and everything is managed in Centrale Operativa Territoriale. So big movement of data. This is a draft, both in Italian stands for draft, of the government plan for the Next Generation EU. We will have 6 levels of services, let's say services. First level is healthy person without any condition, without needs. We have to, not like the old version, you are healthy, don't bother me as doctor. You are healthy, we have to work to keep you healthy. Then we have second, minimal. Then we have third, fourth, fifth. 6 is dying, means end of life. We have, let's look here, simple action, coordinated simple action here, then complex, complex and complex. We have 3 levels of complex and 1 simplex. Where is e-health? E-health is here. This is simplex. In simplex, we start, even in simplex, with digital literacy of the patient. Even complex, obviously, we have to evaluate the capability of self-care and digital knowledge. So we endorse the digital knowledge. Yes, we as doctors and nurses are used to teach the patient, and we are supposed to teach also some digital knowledge of the patient to use digital health services. Then we have the plan of e-health activities for simple and for complex. This is the very, very quick draft of the Next Generation EU plan for Italy for health. This is just an example what happened in the United States. Those are numbers, so millions. You can see the shift from the ambulatory visit and telehealth visit. And the number, you know, in even in the United States, you have north, south, west, and east. Same in Italy. And this is mainly based on culture, people culture. In a recent Indiana University paper, they analyzed the telehealth results compared to culture of the people. Less is the culture, more stronger is the resistance to digital health. And this is the green. In northwest of the United States, this is the green part. This is CO2 reduction for telehealth. So telehealth is green. You know, we pay a lot of money to treat the patient for the disease caused by the pollution we produce to cure them. And this is paradox. We produce pollution to cure the patient. Thanks. This is quick Italian point of view. Those are my contacts. Thank you.
Thank you, Sergio. Thank you. All these presentations would be very interesting to discuss, but we are at the end of the day, and it's at least good to see the different opinions and the different directions that each healthcare system is trying to give within the digital transformation of health. And now we continue with John Meredith from Wales NHS. Thank you, and please go ahead. Put your mic on, please.
Thank you. Thank you very much. Sorry, I started to have a little mild panic attack that my mouse wasn't responding to my my clicks. It happens to us all, doesn't it? Well, first of all, thank you very much for letting me speak. Can you just can you see my PowerPoint deck there?
Not yet, no.
Not yet. There you go. I've messed up with that too. Hang on a second. You should see it now. Is that right?
Urska, if you can. Yeah, we are seeing maybe your other screen. Okay, yes, we are seeing. Okay, now.
Yeah, okay. Fantastic. So yes, thank you. Thank you for inviting me. It's a pleasure to be with you virtually, if not in person. So I'm going to take you through sort of a brief journey about the company, the organisation for Digital Health and Care Wales, and the journey towards an open platform approach. Essentially, you know, I represent an organisation that is predicated on building applications and solutions for health and care in Wales. We're also supporting a national programme called the National Data Resource in delivering, you know, next generation analytical services. You can see basically the word digital keeps on appearing quite a lot. It is front and centre to everything we do. I started my time with the National Digital Team architecting the national solution for diabetes management. And in many of these cases, you know, we sit down with clinicians, we start looking at the data requirements, the clinical workflow, etc., and start to think about what sorts of questions clinicians ask the patient, how we start to categorize them. You know, this is a point about four or so years ago, and little did I know at the time that these granular data items had names in the form of archetypes and templates, and also a process that took the form of what Ian was describing earlier on, OpenAir. And you know, there's no time to actually go into the detail about what that actually means, but at a very high level, you know, I sort of started to discover there was an approach that maybe would be beneficial for us. And at the same time as well, we had colleagues that started exploring, you know, the emerging interoperability standard HL7 FHIR, and wondered if that was potentially going to be a solution. Could we use one or the other, or could we use both? To essentially support the DHCW aim of becoming more data-driven. In 2019, we had a report published for a digital architecture review, and whilst I won't go into, you know, all of the detail, you can look up that that report. It is available online. You know, a couple of the key sort of elements associated with that are about us, you know, establishing a set of architectural design principles, and obviously focusing on the work of the National Data Resource to develop this national clinical data repository. And at that time, also, I was conducting a review into OpenAir as a viable technology for us to adopt. And during the course of that, it pointed to how it can be used in an increasingly blended architecture, that it supports the use cases that we are seeking, but also is complementary to technologies such as SNOMED, CT, and HL7 FHIR. Fundamentally, though, we needed standardized published open APIs, and they could be native APIs that are currently used. They could be, open air file, or they could be a variety of different things. We can't rule out, using what's currently there. The current services that exist, whilst we still have gaps that we need to provision for, those current APIs might persist for a significant period of time. And not everything needs to be replaced. If it ain't broke, don't fix it, etc. Importantly, though, we started to understand that a persistent data model could potentially outlive the application. The open platform being a technology neutral thing, because we're talking about the standards that are for use and not necessarily the implementation of them. So the open platform approach is something that transcends vendor implementations and represents a common guide rail for us to follow. And the open platform is predicated upon data that is stored and managed in a secure and auditable way at scale. And this ultimately, we think, creates an economy of scale due to its reusability in releasing design and development resource over time. So in becoming data-driven, we appreciate that we have to shift our mentality somewhat. Separating persistence from the application first allows data to outlive the application. It's very important for us working in a heterogeneous digital ecosystem. It's also important to maintain vendor neutrality. It's a heritage we have in Wales for our digital services that we're incredibly proud of. But in doing so, we will provide other benefits such as reduced maintenance overheads, etc., etc. After all, the application models that should focus on supporting the application function itself, i.e., the code that goes into apps and other digital tooling, needs to support that principal use case of providing good user experience for clinicians and patients alike. That's the reason why the app needs to be built. The underlying persistence models that can then be developed and maintained independently, that's a really important separation of concerns that needs to be considered, and is now starting to become front and center at everything we do. But this then in turn facilitates programming language independence and again, that reusable component approach of low code. So getting to these goals is an understanding of the facets of interoperability, and this has been alluded to both by Ian and Petra, and specifically about how technology can support these individual facets. Importantly, though, there is no one perfect fit. Our choice of platform technology is predicated upon the use case at hand and whatever clinical problem we are trying to solve at a given time period. But these overall 4 pillars of interoperability may not always be applicable to use cases. But from a national perspective, we're kind of looking at the nexus of these concentric circles sitting right in the middle there. Importantly, combining technologies gives us this best of breed capability. The differences between FHIR and OpenAir, for example, mean that when you use them together, they become more than the sum of their parts. And I won't read all those into detail, but essentially what we're saying is that, we can merge these things together and they will be complemented. So how does this look at a high level? Well, essentially adopting OpenAir for us in NHS Wales would allow us to start that transition from the siloed and document bound to the open platform. We start to build with a future first mentality, but that doesn't necessarily imply there's a lack of complexity. This is inherently hard. Data is stored separately from the applications that collect and edit and display it. The data layer then helps to deliver data that is standardized in terms of format, nomenclature, terminology, definition, etc., which then allows it to flow into other systems as specified and governed by the data owner. Good rules for data storage will not change much, if at all. But by allowing for this increasingly granular, more complex persistence over time, we can ultimately then increase or provide an increasing interoperability capability over time. And, at the top layer there, the application layer requires, a full, systemic design for workflow, which means that it has to know the context and what became for in the patient journey and what comes after in the care journey. But of course, with a maximal approach to that structured data repository as its foundation, we get a lot more flexibility as a result. This is quite a new slide, and it is a very high level logical description of what our emerging open architecture platform is. It's a painting a target of the open platform for us. The key to this is the requirement that data is the currency by which our partners across NHS Wales can transact. So our local health boards, and let me turn on my my little laser pointer, virtual laser pointer here. So our health board partners, for example, can find normalized data for analytics as part of our national data lakehouse initiative. In turn, also can harvest structured data via Welsh Care Data Repository, the WCDR. But of course, over here, we've got a boundary around what our day-to-day work is, or certainly my day-to-day work as part of Digital Health and Care Wales, and this emerging element called the Clinical Data Engine, which essentially is open air plus a low-code eForms capability, so that we can support the emerging use cases, but importantly, reuse the common data structures and data itself for a variety of different emerging use cases, be they whatever the next diabetes solution is, or cancer, cardiology, etc., etc. So I'll leave you with just the notion that maybe we should be data driven and also free that data, because the information model should no longer be the domain of the third-party vendors. As I mentioned, we've got a vendor neutrality kind of concept at the core of what we do. Our core mission now is to facilitate access to data across those organizational and regional boundaries, representing that clinical data in a ubiquitous way for a variety of different consumers. But importantly as well, this replicates the principles that founded the NHS in the first place. We can just substitute that to mean that data access at that point of need. Thank you very much.
Thank you so much, John. And we finished the talks by Zoom, but again, I will welcome Ponciano Oliveira to talk a little bit about the experience here in the northern region of Portugal. Thank you.
Thank you very much. First of all, I would like to thank you the invitation to be here. To Mr. Nunes de Abreu, my colleague and dear friend. The feeling is mutual, and I thank you for your words. Professor João Fonseca, it's always a pleasure to be here in this magnificent institution, and I will take the chance to greet also Professor Altamiro da Costa Pereira and Professor Cruz Correia, also present here. I would like also to greet my colleagues in the table, and I will just have a short brief on this matter. When we talk about the provision of healthcare and answering the question, will the next generation of healthcare systems will be data-driven? Well, I think it demands for a mandatory answer, and the answer is inevitably. They will be, for sure, either voluntary, either pushed by the facts, because the truth is, in our days, we have a huge challenge on healthcare provision. The demand of the increase of costs with technology, with chronic diseases, with the people's expectations, with the technology available, which we'll have to provide at a sustainable costs, will take us to that point. And it's consensual in the literature that in these days, incremental reforms did not solve the problems. We had introduced several measures, such as the administrative reductions of costs, the quality in health, the electronic health record, and it all helped to improve the quality of care, the security of care, and the sustainability of care, but it didn't solve the problems. At this point, we need a new model of provision of care, and that new model is based on increasing the productivity and increasing the value of care which is driven by our healthcare systems. How can we do that? We have been trying the task shifting. We have been trying the patient-reported outputs, and the truth is we need those coordinated systems, assistance systems and processes to get to another level of productivity and value of care driven. Having that said, how can that help, or how that demands for another vision of data for the data in healthcare? It all starts here. We usually talk about in these forums about information or information systems or technology, and only on forums like this we are talking about data, which is the true value that we need for those technologies. We need the information, the storage capacity, we need the process capacity, we need the integration capacity in order to transform that data into knowledge that can support our new ways of providing care, such as value-based healthcare or artificial intelligence, or even to provide it with new levels of social cohesion. We can always think about the menaces that these new ways and expensive ways of driving care, such as artificial intelligence, the gaps that they can create between the richer and poor people. But we must also think about the solution that, for example, telemonitorization or telescreening can give us. We solved some years ago. We have solved a waiting list in northeast part of the region. In what concerns to dermatology, we solved that waiting list, recurring to the telemonitorization of the patients we had there, with increase of quality of care, because of course we have much better facilities here in Porto, and in that region it's not even sustainable to have such sophisticated equipment and resources in that part of region with a low density territory. So returning to our question, I think that it will be mandatory. The systems will be pushed to it, some slower, some faster, but it will be our reality in a few years, because reality does demand it. I just must have some caution. We do have to have some cautions, because, and they were pointed by the colleagues, they will only be healthcare driven, data driven systems if they are data store driven, data processing driven, data secure driven, and data integrated driven, and data reliable driven. Only that way we can transform it into the knowledge that we need for those new models of provision of care.
Thank you so much, Dr. Ponciano, and I'll ask you now to award our global shapers that are present, please.
Thank you so much, panel. This was amazing, and it was a fantastic contribution. We couldn't end the day. I have to apologize for the delay we have, but now we are more or less on time. Calling here that are in presence, the Dr. Mcneillo and Catarina Gomes and Valerie Larsi to come here, please, and be having the certificates from the hands of session co-chairs that we are. Maybe Dr. Fonseca, Dr. You can stay here. Wait, you're in the line, and you come here, and we do the delivery for our artists here are going to take the pictures, and George making it. Okay. And a round of applause for the global shapers. A round of applause. And Valerie, yes, well done, well done. A picture all together, if you don't mind. Also, I'm putting myself also. Thank you so much. Okay, so I think that we can call the session over. Thank you so much. Thank you so much, everyone watching in Facebook. Thank you so much, our guest speakers on Zoom. So sorry that you cannot join us now for the guest speaker dinners here, but maybe on other occasions. I know that all of you tried hard to come here and be in person. COVID is not handed away, but maybe next year we can do this gathering happening. Thank you so much, Reggie. Let's call it the day off. Thank you so much, everybody that support this event. And we faced so many stressful moments, but we overcome them. And now we're going to have some rest till tomorrow. We start here 9 o'clock local time, so please be a little bit earlier than 9 and 10 CET. And of course, the rest of the time zones are in the agenda. Thank you so much, and see you tomorrow.